Hi, Mike Gibson coming to you live from SCAI 2017, talking today with Kostas Marmagiolis and Cezar Iliescu, talking about the cancer patient in cardio-oncology. We have more and more older patients and lots of people developing cancer who are going to get chemotherapeutic agents that are going to damage their heart. I was excited to see that here at SCAI we have a whole session now dedicated to cardio-oncology. So tell us a little bit about the session.
We're very, very excited to have the first section on oncocardiology. It's a brand new field, interventional oncocardiology, and we're very, very happy SCAI endorsed our effort. We've started 5 years ago, and was based on the initial experience on cancer patients with thrombocytopenia, FFR-guided PCI, and a lot of things we've used in practice cardiology. And we've adjusted our field and our steps to provide cancer therapy.
So a lot of the adjustments have been getting the dose right and things, but are there going to be things coming along that will protect against the damage to the myocytes?
So we know that people with cancer now live longer.
Right.
So those people get effects not only from the cancer itself, because cancer affects the coronaries with different ways. They have more clots, they have more atherosclerosis, but also they get the effect of the chemotherapy and the radiation therapy, both of them affecting the coronaries. So those people live longer, and we are starting this field trying to protect those people. Our first step is to protect them from developing the effects of the side effects of the chemotherapy, radiation therapy, knowing that those people now live longer. So the whole idea is to create this field and find the ways to protect them in the long term. And as a second step is to assess them whenever they develop an acute coronary syndrome and manage them in the cath lab more effectively.
Yeah, I just remember so many cases of mantle therapy-induced proximal kind of LAD disease. Are there any ways we can help protect the coronaries from the radiation?
It is a very interesting question. Tomorrow in one of our sessions, we're going to present OCT images of radiation-induced coronary disease. And we know the good correlation between OCT images and the pathology. And we're going to present beautiful data about stenting, maybe revisiting the idea of stenting and maybe using balloon-eluting medication rather than stenting because of the additional understanding the OCT imaging has provided to the atherosclerosis in young patients.
Yes.
Now, that being said, we've seen it really varies from different segments of the coronary system, and really almost within a few millimeters you can see difference in the structure of the plaque within the coronaries, which makes it even more challenging. So I do believe that we have big challenges ahead, but we also have the technology, the tools now, our invasive tools to provide better understanding.
Now, a lot of, as someone who does a lot of work in atherothrombosis, a lot of the risk of thrombosis in cancer patients is mediated more on the coagulation side than the platelet side, and a lot of active work in using factor Xa inhibitors to minimize the clots that form as part of these neoplastic syndromes. Is that part of what we should be doing in some of our coronary patients?
I think that's a great question, and it is more challenging now for us cardiology to provide an answer. The reason is the American Society of Clinical Oncology, ASCO, has considered our DOACs as a relative contraindication in cancer patients.
Now that's kind of odd because there's a fair amount of observational data showing better outcomes.
And we started providing this indirect data to support our therapies and change, but the initial statement was such that it made it a little obstacle for us to provide the data and use it. So we had to have this discussion with the patients, explain them the risk benefits and why we believe, again from initial, even from Aristotle trial, in other trials we had cancer patients included, few patients, but we had patients included that we believe it is easier to administer, safer, again with the same stone we hit more birds. And then it provided in the long run better outcomes. But it is a challenge for us as well. I think that antiplatelet, anticoagulation regimens are one of the big questions we can answer in our patient population, especially thrombocytopenia and other challenges that we have to
and this is the big challenge for us, because we know that there is a risk of bleeding in most of those patients with thrombocytopenia and anemia, and on the other hand, there is a risk of thrombosis.
Right.
Because also the people who get stents, they take longer to endothelialize inside the stent. So those people need more aggressive therapy. And also those people may have to stop their medication prematurely. They may need to have biopsies, change of treatment, unpredicted surgeries.
Right.
So our idea is to find a way to make our work in the cath lab as optimal as possible by using IVUS and OCT after treatment to make sure we oppose the stent well and do the best we can to endothelialize the stent as fast as possible, so in case people need to stop prematurely their therapy, to have the best chance of being well endothelialized and not having a thrombosis event.
And a very interesting component, it's our work that we've done with OCT, actually together, is that you would think that is us driving the procedure result. The interventionalist doing a perfect procedure and having optimal angiographic results, but what we've seen is worse outcomes in patients that have worse cancer. So it may be a healing process that's really patient-driven, and maybe that the suboptimal results we have in some cancer patients may be really because of more advanced cancer predictive for outcomes. So it's not really cardiovascular-driven, but really cancer-related comorbidity, additional comorbidity.
Well, as people are getting older, we have more and more atrial fibrillation and ACS. As people are getting older, we have more oncology and ACS, and so it's going to require an adaptation of our techniques.
And you want to talk about what we discussed about the...
Yes, we also, that is a very good question, because those people with atrial fibrillation and with other thrombotic events, they will need triple therapy. So structural procedures are moving forward, and maybe the exclusion of the left atrial appendage procedures will be the next step for us. We were discussing about trying to involve more cancer patients in the exclusion devices to protect them from having events. So this is a new field that we want to get involved more.
Very good. Well, guys, thanks for joining us today. And thanks to all of you for joining us here live from SCAI 2017.
Thank you.